Thank you. So lucky to have Marisha on my team. She always looks out for me. Thank you so much, everyone, for being here today. My name is Dr. Patricia Gonzalez, and I serve as Assistant Dean for Justice, Equity, Diversity, and Inclusion. We're super excited for today's conversation in honor of Women's Herstory Month, right? Her Story Month. We want to thank you for joining us today for today's conversation with Dr. Stephanie Lemus on the topic of improving Latina women's health. The COVID-19 pandemic impacted underserved and BIPOC communities, and specifically, and the most, right? And so the virus really impacted Latinx communities as well, which is why we're super excited that Dr. Lemus is going to give us some insight about that and the model that will provide how to improve or prove more effective ways to dismantle what has happened in that community. And so we're super excited to welcome you to the space, Dr. Lemus. Thank you for your knowledge. And so before we get started, I want to give a shout out to Be Well. I'm going to pass it over to you, Erin, to introduce yourself. Be Well is our co-host for today's conversation.
Thanks so much for the introduction. Really excited to be attending and co-hosting this event, and welcome to all of our participants. Wanted to share really quickly a little bit about Be Well. It's a college initiative, College of Arts and Sciences, based on the belief that members of our community are our most valuable asset. We aim to bring the 8 dimensions of wellness to life by encouraging behaviors that generate wellness for students, employees, and community members in a fun, inclusive, and accessible way. We promote the benefits associated with college life by drawing upon research and expertise of our CU faculty, and also amplifying the range of resources that the wellness resources that our campus has to offer. Today, I'm so proud to be collaborating with the Arts and Sciences JEDI team, and it's a great privilege to welcome Dr. Lemus for this event. So thanks so much.
Hi, everyone. I wanted to introduce myself. My name is Marisha Lopez. I am the Program Manager for Justice, Equity, Diversity, and Inclusion in the College of Arts and Sciences. And before we get underway, I just wanted to guide us through a land acknowledgement. We invite you to take a moment to reflect on your relationship to this land of Boulder and relationship to local Indigenous communities as we are guided by the university's land acknowledgement. The University of Colorado Boulder honors and recognizes the many contributions of Indigenous peoples in our state and in stewardship to land before the establishment of the state into this present moment. CU Boulder humbly acknowledges that it is located on the traditional and current homelands of the Cheyenne, Arapaho, Ute, and many other Native nations and communities. The violent, forced removal of Native people from these territories has caused devastating and lasting impacts. These histories have brought us to the present moment, wherein the University of Colorado Boulder is determined to commit to improving and enhancing relationships with Indigenous communities and issues locally and globally. We will do this by recognizing and amplifying the voices of Indigenous CU Boulder students, staff, and faculty, educating, conducting research, supporting student success, and integrating Indigenous knowledge. And lastly, consulting, engaging, and working collaboratively with Native communities. There will be a few links in the chat if you take a look that can help guide you through your education on this subject. And I have the great pleasure of introducing you all to Dr. Stephanie Lemus. Stephanie Lemus grew up in Pico Union, Westlake area of Los Angeles with her Salvadoran immigrant mother and her 2 siblings. She attended California State University Northridge, where she double majored in anthropology and Central American Studies with a minor in Pan-African Studies. After graduating from CSUN, she then entered a master's degree in Latin American Studies from California State University, Los Angeles, where her primary research focused on the community of the Salvadoran diaspora in Los Angeles. In 2021, Stephanie earned her doctorate in education from the University of Southern California, Rossier School of Education. She has worked with various nonprofit organizations and groups for the past 12 years in community outreach, education, healthcare, workforce development, and advocacy. Currently, Stephanie is an adjunct professor at CSUN's Central American Studies Department, and also is a strategy consultant at Uproot Talent, a search and talent advisory firm dedicated to attracting, hiring, and keeping executive leadership and co-creating anti-oppressive cultures. She serves as board president of El Rescate, an immigration legal services nonprofit, and is a board member of the Central American Policy Research Institute. Additionally, Stephanie serves as a commissioner on the Los Angeles City Health Commission. So join me, everyone, please, in welcoming Stephanie.
Thank you, Dr. Cunningham, Dr. Gonzalez, and Marisha for the warm welcome. I'm going to go ahead and share my PowerPoint. Please let me know if you can see it, thumbs up, just the way that I can know that I'm doing it correctly. See? Yeah, okay. Let's get started. Okay, well, again, good afternoon, everyone. It's a pleasure to be in this space virtually. Thank you again to Dr. Patricia Gonzalez, Marisha Lopez, and Dr. Cunningham for the opportunity to engage with everyone. Before we start today's conversation, I do want to acknowledge that it's important for everyone to understand that the framing of today's conversation is not isolated from my own interests, my background and experience. As mentioned, I come from an immigrant background. My family escaped the Central American region in the 1980s, like millions of people did back then, and continue to do so because of the rampant violence, political instability, authoritarianism, economic decay, and the lack of social, economic, and upward mobility, and of course, rampant human rights violations. And so my experience as the daughter of immigrants in the United States as a first-gen college student has fueled my passion, has fueled my work in social impact, and so in the United States, and so specifically creating opportunities, resources, tools, and the conditions for the Latinx Central American community in LA to thrive and flourish. So I wanted to center that as part of the conversation before we get started. So health equity, health disparities. It's important to frame this conversation today around these two concepts and ideas that get thrown around a lot. And so what do these two concepts mean? Health equity, it just means that everyone has a fair shot. Everyone has an opportunity to attain their full health. That no one is disadvantaged, excluded, or dismissed from achieving this potential. And so really addressing the structural conditions of inequity in health that have permeated historically disenfranchised and marginalized communities such as racism, sexism, and income inequality, and how all of these items impact disadvantaged communities. And so when we talk about health disparities, on the other hand, these are associated with social and economic disadvantages. Social and economic disadvantages that adversely impact communities of color, marginalized communities, who are consistently over and over again experiencing these social and economic obstacles to health, with factors that influence health. And these factors are based on ethnic group, it can be based on gender, age, disabilities, gender identity, geographic location, or other characteristics. And so again, as we think about the Promotora De Salud model, it is a small part in this large road, right, to health equity and mitigating health disparities in the Latinx community, specifically for Latina women. Let's look at Hispanic Latinx health in the United States. And before I even start diving into some of the, the more rampant ailments in this community, I want to acknowledge that I'll be using Hispanic, Latinx, and Latino interchangeably. And that's just because, for most of medical research and work, these are the identifiers that conglomerate a large amount of diverse and very unique peoples that come from all over Latin America, the Caribbean, and not only do they come from various regions, countries, etc., but they also don't just speak Spanish, right? And that's the Hispanic part, right? Spanish speaking. And so I wanted to acknowledge this because again, individuals speak more than just Spanish. We have community members, Latinas, who speak Indigenous languages, who speak Afro-Indigenous languages. And of course, the region, all of Latin America has experienced more recently arrived immigrants that even adds more diversity to the peoples that we know under this very homogeneous terminology, right? Like Latin, Latino, Latinx, and Hispanic. So I wanted to center that, just acknowledging that when you think about the experiences of Latina women, the identifier itself really mitigates the vast experience based on intersectionality that someone can have from being Afro-Latina or being Indigenous, etc. So I just wanted to acknowledge that. So, obesity, diabetes, hypertension, chronic kidney disease, and cancer. These are some of the most rampant diseases and chronic illnesses that are taking our community. Obesity for Hispanics, the community is 1.2 more times more common than non-Hispanic whites to suffer from obesity. And this is a problem because obesity can cause other health problems, and so it's important to prevent it. Diabetes is estimated that about 40% of Americans will develop type 2 diabetes during their lifetimes. But for the Hispanic Latino community, this is even more so. It is estimated that over 50% of Hispanic Latino Americans will experience and develop diabetes in their lifetime. As we go into the next area, chronic kidney disease, Hispanics are more than 1.5 times more likely to suffer kidney failure than other Americans. Hispanics also make 20%. So 20% of Hispanics are waiting for kidney transplants. So not only do they have more likelihood to suffer from kidney failure, but they also encompass a large percent of those that are waiting for kidney transplants. And then lastly, when it comes to cancer, although Hispanics and Latinos are generally have less percentage of cancer development than whites or Caucasians, the research shows that overall immigrants that are born outside of the United States, so Hispanic Latinos that are born outside of the United States, are more likely to develop cancer related to infections such as stomach, liver, or cervical cancer. And just based out of my work in the community health center environment, what we saw post-pandemic was that a lot of our community members not only were impacted by the higher rates of COVID-19 infection and death rates, but also a lot of interrupted care during the pandemic. Why is that? A lot of Latinos, Hispanics, Latinx community members never stopped working in the community, right? They were domestic workers, they were working in service industry jobs, they were picking our fruit, they were in the farms. And so not only were they not working remotely, right, and not working safely from home, that made them more propense to COVID-19 infection, but also it meant that their care was interrupted. And so what we saw at the community health centers was that as restrictions eased, a lot of individuals that had not had preventative screenings were now presenting stage 4. We're now presented with late stage cancers. And we saw this in the Pico Union, Westlake, and Boyle Heights area of Los Angeles, which are predominantly Latino communities that were greatly impacted by the COVID-19 pandemic. So now as we go into Latina women, health disparities and how they're persistent, they're enduring, some of the main barriers to Latina women's health are language barriers, health education barriers, and income barriers. So women from Latino backgrounds are more prone to cancer, heart disease, and cerebrovascular disease, and experience a shorter life expectancy than women from white backgrounds. And so these barriers directly contribute to health disparities for Latina women compared to non-Latina women. And so as we look and dive deeper into these barriers, when it comes to language barriers, most of Latinas speak Spanish at home. And so even though they may speak English, according to the U.S. Census Bureau, 13%, almost 14% of U.S. residents spoke Spanish at home. And so what it tells us is that a significant portion of Latinas are primarily Spanish speaking and may possibly have limited English proficiency. Going into health education barriers, access to health education is limited for Latina women. And of course, many Latinos and Latinas experience discrimination and lack of culturally appropriate health education when they seek advice or care from providers. And lastly, income barriers. When we look at the federal poverty level across the nation, and we dive into the Latina experience, about 31% of Latina women who earned $25,000 a year or less are more non-insured than compared to 16% of white women who are uninsured. So 31% of Latina women who earned $25,000 a year or less were more gravely uninsured compared to only 60% of white women. And to give you an example of thinking about like the federal poverty level and what that indicates, so a family of four, according to the federal poverty level, that has an income of $27,000 or less is considered to be at the 100% federal poverty level. So that is an income of $27,000 or less. A family of four is considered at the 100% of the federal poverty level. So when we think about the barriers to health, not only do we have to think about Latina women, but the entire family. Because how can we think that a family can survive, right, on $27,000 for a family of four? And just thinking about the great barriers, not only health-wise, but thinking about the whole family comprehensively. So access to healthcare. Latinas across all ages were definitely less insured than white non-Hispanic women. Again, according to the U.S. Census Bureau, despite gains in health insurance coverage like the Affordable Care Act, Latinas continue to face significant coverage disparities when it comes to healthcare. And then in the U.S., Latinas have the lowest coverage rates of any racial or ethnic group. So again, as we look at our nation, Latina women by far have the lowest coverage rates when it comes to healthcare of any racial or ethnic group. And as we think about Latina women and their intersectional social identities, immigration status is definitely a factor. Most individuals get employment-based or public programs assistance for some type of health coverage or preventative services that either come from the state or the federal government or a mix of both. And so unfortunately, that means that immigrant Latinas have less insurance coverage, primarily because of socioeconomic circumstances that make them ineligible for these programs, mostly because of their status, because also they have lower status jobs without insurance coverage, right? So thinking about employment-based coverage, and typically work in job industries that do not typically offer employment-based health insurance. And so because of this, immigrant Latina women are most likely to be ineligible for certain public insurance programs, but also employment-based programs. And the other factor when we think about access to healthcare is also acknowledging that Medicaid varies in access by state. So every state has different access to individuals for low cost and free reduced health coverage. And so Medicaid is just the health coverage that is provided to millions of Americans, including eligible low-income adults, children, pregnant women, elderly adults, and people with disabilities. And in my state, in the state of California, these Medicaid access is also expanded to undocumented immigrants. And I'll talk more about that, about the Medicaid, or what we call here Medi-Cal, expansion to undocumented individuals, including children and seniors. And so, of course, Medicaid is administered by the states according to federal requirements. And the program is usually, again, jointly funded by the state and the federal government. And in California is leader among states. It really has set the tone on how to reimagine access to healthcare and how to make healthcare coverage and services more accessible to undocumented immigrants. And recently, Medi-Cal, which is again California's Medicaid healthcare program, has had various expansions for the undocumented population in the last 7 years. It started back in 2016, where children under the age of 19 years old became eligible for full scope Medi-Cal benefits. And then after that, in 2020, full scope Medi-Cal was extended to young adults. So this included young adults, children from the age of 19 to 26. In 2022, that expansion was further to undocumented seniors. So when we talk about full scope Medi-Cal, we're talking about no cost or low cost healthcare services like mental health, substance use disorder services, vision, dental, and home and community-based services. California's last expansion was recently in 2022, where it included individuals of the age of 50 years of age or older. And California will now add to that expansion in 2024, where full scope Medi-Cal, right, so an array of services that I just mentioned, that will be now eligible for those who are 26 to 49. So that was like the last age gap that was left for California. And so when we think about healthcare for all, California is really making really big investments, right? When we think about like the economic investments to improve undocumented individuals, and the Latino community greatly benefits from having these expansions for all undocumented individuals, regardless of status. And so now, what is the Promotora De Salud model, right? What is the CHW, the community health worker model, and how have we seen that it's a proven difference in the community-based setting? The Promotoras de Salud are lay health educators who promote health in their communities. They provide leadership, peer education, support, and resources to support community empowerment, or capacitación, which is like capacity building. And so the very unique aspect of community health workers is that not only are they from the populations that they serve, but they mirror the communities that they serve. So as members of minority and underserved populations, they're very effective in reaching minority populations, specifically Latinx community members, because they're in this unique position, not only to build on their strengths of knowing the community, being from the community, but they also understand and have experienced the areas of unmet health needs in their communities. So not only are they, do they first-hand experience these unmet health needs, but they see it in the community as well. And so Promotoras de Salud, or community health workers, integrate information about health and the healthcare system into the community's culture, right? So when we think about culturally responsible and culturally appropriate education, they really have a way to really dismantle and deconstruct very information that might seem out of hand for community members, and use the community's culture, their language, their value system, their lived experiences, really knowing the community to turn this information around and deliver it in a way that is accessible for the community. And so These community health workers, with the right training and support for community-based organizations, healthcare providers, healthcare systems, they're able to link their neighbors to healthcare and social services, educate their the community members and their peers about disease and injury prevention, amongst other things, and also work to make available services more accessible and mobilizing the communities to create a positive change. So it's an exchange, not just of the individual relaying information, educating the community, but there is an exchange between them and the community about how, not only how to improve the individual, the family, the community's well-being, but how to make those macro changes. And I'll talk more about how Promotoras de Salud and community health educators really take a really important part in policy and advocacy as it comes to health disparities and health equity in communities of color. So the broad understanding of the promotora and community health worker model, we need to frame it that these individuals who are recruited from their communities, who are already leaders in the communities in some sort, they're already leading their PTA meetings at schools, they're organizing their community members to change, their unmet health needs or other social needs in their communities. These are already leaders on their own that are identified by community health centers, like where I worked at Clínica Romero, by other healthcare providers, to be these trusted messengers. These individuals are trusted messengers who are trusted people to where community naturally turn for advice, for emotional support, and other types of tangible aid that is needed in some sort of their social needs. And so Promotora de Salud-based interventions are commonly grounded in social cognitive theory, which relates both initiation and the maintenance of behavioral change. And so in this model, health change is conceptualized as occurring both within a network of social influence, right? And so this is where the trusted messenger aspect comes for the Promotoras de Salud. They're able to work within this network of socially influencing community members to make these changes. So rather than just focusing on an individual, they're really creating this sense of community, the sense that not only community members can trust them with information about health and health education topics, but that they're able to link them to all their other social services needs and also engage them in other more meaningful ways. And so Promotoras de Salud really serve as an active social support for community members, and these social support networks that are created in Latinx community members extend beyond family, right? People really trust neighbors and peers and friends as part of an extended family. And so as opposed to maybe asking a healthcare provider about symptoms or other ailments, they're more likely to talk to a family member or a friend, or in this case, a promotor de salud that it understands their experience, it understands where they come from. And so the Promotora de Salud, they serve as a complementary role amongst this social network as an extended family, as a source of support, as a source of advice, a social interaction, and also as social role models, because the Promotora de Salud model, right, those behavioral changes, those health changes that they are teaching the community members. And so, again, continuing in this conversation of Promotora de Salud being trusted messengers, again, it's important to emphasize that promotoras typically live in the communities that they work, and so because of that, usually their ethnicity, their socioeconomic status, their language, right, or languages. In this case, thinking about indigenous Promotoras de Salud. Cultural norms and beliefs, they match the population they serve. And so, for example, one of the things that we learned early on as we were disseminating COVID-19 health education and informational material is that we knew that we had more than Spanish speakers, right? Not only did we have English speaking Latinx community members, we had Spanish speaking Latinx community members, but we had Quiche, Canjoval, and other Mayan indigenous language that were part of our community. And so not only was it important to disseminate information that was language appropriate, but it was also important to identify Mayan community health workers to relay this information, to do videos in their language. So really taking the community that you serve in every step of the way as you develop your Promotora De Salud model, your community health worker model. So really being able to see the different social identities that exist in your communities, and that includes language, cultural norms, and really being intentional about your community health worker model. And so again, community health workers should be members of the communities where they work, should be selected by communities. So in my case, our community health worker model, it was a community health worker that had kind of risen through the ranks, if you can say. She was well connected in the community. She was part of her housing authority committee, where they decided collectively as a community on projects that would be initiated in the community. She was closely tied to the local schools. And so this community health worker that was more well-seasoned was the one that would go around different schools, different community-based organizations, and really identify other potential community health workers based on their leadership and their linkage and their connection to the community. And so again, not only should they be selected by community members, but they should be answerable to the communities that they work in. Because they are part of supporting the health system, not as a part of our organization, but again, as this exchange with community members. So lived experiences, cultural ties, social networks, these are the not on paper aspects of community health workers that makes them such trusted messengers. There's been a lot of changes, specifically in California, as we think about community health workers and what we value as experience or as knowledge. And so important in community health workers in the model that is grassroots, that is intentional, that is very community driven, is putting an emphasis, not only that these community health workers are part of the communities that they work, live, and play in, but also that they have lived experiences that matter. That they, that they can connect to community members about migrating north, right? Migrating to the United States, that they can talk to community members about experiencing substance use disorder in the family. And so I want to center that because part of the effectiveness of the community health worker model is the community empowerment, right? Through their cultural ties, through their lived experiences. So social networks, this sense of community, right, that is developed in the community health worker model, the Promotora De Salud model, and also community empowerment. These are two main constructs that inform the community health worker model. And so this model is not only centered on enlisting, training, and empowering naturally recognized leaders in the community, but also how these community health workers can link other community members to existing healthcare services with the end goal to improve and maintain healthy behaviors. And so the Promotoras de Salud, again, because they're so embedded in the communities that they live in and they work and play, they really understand the social networks of their communities. And again, they're trusted and respected individuals in their communities. And so people will naturally turn to them for advice or assistance, whether it's in the healthcare realm or any other social services that they might need for themselves or for their family. And so the trust that people give promotoras is a very critical factor and has an important significance because it allows healthcare services, healthcare centers such as Clínica Romero, and researchers like a bridge, an entry into this community, and by large acceptance by community members. Because let's face it, there is a very big gap, not only in being able to engage people of color in research that will at the end benefit them. And at the same time, getting this research and information back to them. You know, as an academic, I always say your research is only as good as the people that you utilize in your research and as your subjects. How is that going to give back to them? How is your research going to not, you know, reproduce this colonial aspect of utilizing your subjects, reaping, exploiting information, etc., any other thing, and then it's not going to benefit them. And so the promotoras also serve not only as a bridge to the healthcare delivery system and healthcare centers and hospitals, but also an entry point for research. And so the Promotoras de Salud really are a bridge to that, bridge the gap between the healthcare system and the community. So, important in this framing is also understanding the social determinants of health, which are just the conditions and the environments where people are born, where they live, where they work, where they play, where they worship, which has a wide range of health impacts, that has an impact on the quality of life of individuals, that has an impact on their health outcomes and the risks. And so in addressing the social determinants of health is how we really, as a community, make progress to health equity. SDOH, or social determinants of health, it's been shown that it has a greater impact on health, even more so than genetic factors or access to healthcare services. And so as we think about SDOH, poverty, we know that poverty is highly correlated with poor health outcomes. I'm sure all of you have heard, your zip code determines your life expectancy, that determines your health. And so the impact of SDOH is immense, and it's deeply embedded in our communities and in our society, where, within this realm of education, economic stability, healthcare access, it really determines the health of our community. And so, of course, these inequities in all of these areas put people at higher risk of poor health. And these are mostly communities of color and historically disenfranchised communities. And so as we dig deeper into what an SDOH approach looks like for community health workers, as we look at each one, community health workers tackle on SDOH through different ways of informing, linking, and educating the community. For example, when it comes to economic stability, Promotoras de Salud, community health workers, especially during the pandemic, it really meant filling in the gap in terms of food insecurity. So that meant being able to connect community members to food banks or food distribution centers. It meant that community health workers were supporting with healthcare insurance coverage, enrollment, and renewal. A lot of the lax policies, at least in California, were the auto renewal period. The renewal period was auto renewed for people that were in Medicaid or Medi-Cal coverage. That's no longer a factor now. It's going to phase out, or it has been phasing out in many states, including California. And so it meant that community health workers were supporting with getting insured, making sure that they knew that, once they were insured, that there was automatic renewal. And so they had not to be afraid of losing coverage during the pandemic period. Economic stability from the community health workers also means that they help community members enroll into what California calls CalFresh, or nationally is known as the SNAP Supplemental Nutrition Assistance Program, or SNAP. So, leaning onto that and making sure that families that were low income and accessible and had access to apply, that they would do so to help their families and their socioeconomic, variance through the pandemic. And of course, connecting community with housing resources and placement, for example, shelters and LASA. And so just with this part of the economic stability, we already the Promotoras de Salud are almost like a bank of resources. They just, I would always tell the community health workers, La Promotora de Salud, you are from A to Z, just a wealth of resources for the community. And so, and the next item, in social and community context, how are community health workers improving the Latinx community members' political participation, which is, it could be from voter registration drives, educating about the importance of political and civic engagement, whether it's in the neighborhood councils or in the last 2 years, thinking about redistricting in LA County. Also, how to improve their health by acquiring status. That means the community health workers do naturalization workshops around immigrant status, informing people about their rights as immigrants, and also inviting patients or community members to become part of patient advocacy committees, whether it's at the healthcare center or in any other community-based organization that promotes wellness and health. For neighborhood and environment, that could look like community health workers, the Promotora de Salud, activating the community, the Latinx community, in active lifestyle workshops like Zumba, Tai Chi, amongst other aerobic exercises. It could also mean housing and transportation, aid and information, special programs to help people get housed, and also for free transportation. One example I'll give is LA has this program called Blue LA, which are electrical vehicles that are available in very densely populated areas of LA, mostly Latinx communities that are very low cost electrical vehicles that support the community and being able to move around the city. And so the Promotora de Salud were engaging community members in my work to connect them to these electrical vehicles. And in the healthcare realm, being able to connect community members, again, being this bridge with the health centers, with hospitals, that could, give the community members this sense of trust and relief, mostly in the Latinx community, based on fears, the real fears of having immigrant status or having mixed status families. They really serve as a bridge to give the communities this sense of relief, of comfort, and trust and information about how to go to community health center, how to go to these healthcare service providers and enroll and, get active into being able to provide health, to get healthcare services. And lastly, education. The community health workers play a very important part in being able to connect the entire family, from adults to youth to education, whether it's higher education, adult education, nutrition workshops that further the education in health or other topics. And so in my experience, we connected with not only California State University Northridge, the institution where I work at, but also community colleges to offer nutrition certificates, also naturalization workshops, and also in classes, and also engage youth and university students to become community health workers themselves and learn more about the model. So the Promotora model that in my work I disseminated is this range, right? From engaging, informing, educating, linking, and giving a nudge to the community. And that's that trusted messenger part where you're nudging people to have real behavioral changes and to really further understand their realities in the context of their health. And so in the Promotora de Salud model, in which these community members are being served, the Promotora de Salud, or the community health worker, engages the community and builds relationships. That's the trusted messenger part, right? Based on both not only the trust, but respect. When you respect and trust someone, you're more likely to take their advice, to really, not only listen, not only hear what they have to say, but really listen, right? And really deconstruct that information and take it in and take it into consideration. And so secondly, the Promotora de Salud model informs the community of critical health information and resources that at the same time educates them by explaining the benefits of healthy behaviors and also health services. And this could be health services mostly tied to community health centers, or also just informing them about what a health plan is, what an IPA is. There's a lot of lingo in the, just the healthcare institution as itself is a monster when we think about health plans and coverage and state-based programs. And so the Promotora de Salud are able to navigate these very complex, systems into something that is relatable to the community. And so lastly, the last two things is not only are they educating them by explaining, the benefits of healthy behaviors through health education programs and health services, but also they link the community members to these needed health services and help them navigate the process of accessing services. Many community members are turned off by the paperwork, by the waiting period, by these, hundreds of, pages of information that is, first of all, not language accessible. And so the community health workers are able to navigate that. And lastly, the community health worker model, or the Promotora de Salud model, is able to support and nudge, right? Like a gentle nudge that is given to community members by positively reinforcing healthy behaviors, right? Not only modeling those behaviors, but reinforcing those healthy behaviors, such as accessing needed health services. And so the Promotoras de Salud are able to engage not only in, informing, educating, linking, but also an important part of their exchange with community members is being able to serve as policy and advocacy agents. And when we think about the macro system, so really being able to engage community members and having a stake about how to change the access to healthcare services, how to increase health equity in the communities, and how to improve health outcomes in the communities that they serve. And so to give you two examples of two projects that I personally led in my work, I'm going to talk about two projects that were conducted in LA County. These projects were funded through the Department of Public Health and also USC Good Neighbor campaign. So in these two projects, the main targets were Latinx community members, and most of the participants were Latina women. And so these outreach programs were conducted in LA County. So we see the picture here. LA County is huge, right? It has urban areas, it has rural areas. And so these programs were conducted in service planning area 2, 4, and 7. So you see here, right, this is 2, 4, that's more like downtown LA, and then 7, that's more of like the eastern part of LA. And most of these these projects that I led were predominantly in low-income, monolingual Spanish-speaking and uninsured Latino population participants. Over 80% of the participants in both of these projects were Latina women. Most of the patients or most of these participants live or were well below the 200% of the federal poverty level, or 84% under the federal poverty level. And again, just to reiterate, in both of these projects, we're talking about a very highly impacted community. A lot of these community members are not only were impoverished before the pandemic, but greatly so after, during and after the pandemic. And to give you an example of how the pandemic, just thinking about infection rates, most of the communities that we serve in LA County, specifically in service planning area 4, that encompasses downtown LA, so Pico Union, Westlake, and Boyle Heights, which are two very historically Latinx, Central American, Chicano communities, which I would say have more than 90% Latino populations. While the county rate for infection for COVID-19 at its highest point were 12% to 16%, the community health centers that were serving folks in these two communities in LA County and service planning area 4, as opposed to LA County's 12 to 16% positivity rate, these clinics, their patients had 29 to 40% positivity rate. So double that of what LA County was experiencing. And so in these two projects, again, more participation of women, and that's of course due to cultural factors. So 85% of them were Latina women. All participants were participants of color, of course, and low income participants. And so in this project, in the first project I'll talk about, which is the CHW project for COVID-19, the outlook was to be able to serve community members with healing informed grassroots community outreach to ensure that they were up to date with information regarding COVID-19 and that they had access to personal protective equipment, such as reusable face coverings and hand sanitizers that reach all community members, especially those that were mostly highly impacted by the virus, right? Not only in infection rate, but also in death rates. And so some of the key messages that were disseminated in this campaign, what was COVID-19, how could you spread it, vaccine safety, how to access services, including but not limited to social services, health insurance, how to respond if a public health agent called you for contact tracing. And so all of these different questions that the community had. And so the community health workers and Promotora De Salud really had a job of dispelling myths, conducting almost like a rumor control, but also being able to connect them to services and also where to find other additional social services. And so some of the achieved deliverables out of the community health worker project were that we reached over 50,000 individuals, with over 95% of them being of Latinx descent within 2 years. And so not only were we able to give them and dispel the myths and these key messages, but out of those 50,000, over 50% of them got vaccinated. So we were able to see this immediate behavioral change, right? Like giving the information, creating that trust, making sure that they knew that we were trusted messengers, a trusted space, and they knew that, you know, immigration status was not a factor and they could get safely vaccinated with us. And so, again, this was conducted with other trusted messengers, community-based organizations, schools, charter and public schools, faith-based organizations, and just other stakeholders like elected offices. So over 150 events were conducted within a year period to achieve this. The second project I'll talk about is the Diabetes and Prevention Awareness Program. This was done throughout, I would say, it was about 4 years. Because of the pandemic, two of the sessions were in person and 2 of them were online, just due to the restrictions. In these 4 years, we had more than 433 participants. So more than 400 participants, where 85% of them were women. And this was based on 4 workshops, intervention style on diabetes prevention. And how do we see that there was positive changes? We did pre and post test surveys on self-reported behaviors and diabetes knowledge. And based on these workshops, we knew that 90% of all participants not only learned new information, 80% of them changed their behaviors, whether that was drinking less soda, being watchful of their calorie intake, if they were already experiencing diabetes, making sure that they were, watching their A1C levels. And so we found that the interventions, though, were most effective in person rather than online. And so after this whole entire conversation, what does that lead us to? What are the opportunities for the community health worker model, the Promotora De Salud model, as we think about the Latina women and their health? Definitely, there has to be this persistent and real investment in continuing to build up those community networks and ties with community health worker models. That means promoting this program in all aspects of social and civil life, whether it's community-based organizations, whether it's healthcare settings. There has to be a real not only promotion of the model, but also continuing to hire people from the community, Promotoras De Salud, that can have an emphasis on their lived experiences that can help Latina women mitigate and curtail a lot of those elements that I talked about earlier in this presentation. Really improving also, secondly, health literacy, health outcomes, and being connected to community members. This notion, right, of really taking into consideration who you're serving, making sure that your health literacy, educational pamphlets, flyers, that there are with the input of the community, that you really assess who you're serving, that you're making this language accessible, that you're taking into account immigration status as you're dealing with the Latina community, and making sure that, my third point, working with local, state, federal entities to acquire more funding. We saw through the American Rescue Plan, right, that ARP, that a lot of funding was made available for COVID-19 projects with community health workers being at the base of that and being at the forefront of that work. But a lot of that funding, we all know, disappeared, right, or is slowly phased out. And so making sure that community health workers are at the forefront of advocacy and policy decision making when it comes to how funding is being channeled to communities of color and Latinx communities. And lastly, I wanted to point out Texas. Texas is a model of a community health worker infrastructure. Not a lot of states have a community health worker state level certification, and Texas does. As you see here in the image, this is more related to states that reimburse services for community health workers, and creating a community health worker infrastructure at a state level is an important part of that. Some states through Medicaid, or like in California through Medi-Cal, have reimbursable services for community health workers. So that means that community health workers are providing some type of health related service to community members, whether that's in a clinical setting or in a community-based setting. And so looking at Texas, California doesn't have a state level certification yet. I know that there's various institutions that have disseminated some type of certification, but we don't have like the infrastructure at the state level. And so Texas implemented a state legislative certification program back in 1999. So it's been quite some time, and they've been able to certify thousands of community health workers that then have, had a great impact in the communities. And so as we look at the future of Latina women's health, community health workers are an integral part of the community. They are trusted messengers, and they should definitely be at the table of policy and advocacy decision making when it comes to how to better serve Latina women and how to create health equity in our communities. So thank you.
Thank you so much, Dr. Lemus, for your presentation and for all that you've taught us today. We have a minute for Q&A. If anyone wants to share some love in the chat, you're also welcome to. Thank you so much, everyone.